topic for presentation. That is the 12 reasons to choose Ticagrelor. So just to introduce myself, my name is Dr. Deepak Shinde. I'm a consultant interventional cardiologist. I've been in Mumbai since last 22 years, and now since 1 year, I also am attached to my own hospital, which is in Dubai, which is which is in the North Maharashtra, right? So the topic which is of Ticagrelor has been really my favorite topic, because the drug itself is my favorite. Since last at least 5 years, I've been using this medicine very regularly, particularly when I have had certain bad episodes with clopidogrel. Particularly as I'm an interventional cardiologist, as you know, this medicine is mainly a medicine which is chosen by interventional cardiologists. So you can understand what I mean to say that. Anyway, so let's go with the topic, that is the 12 reasons to choose the Ticagrelor. Can you go to the first slide, please? So why do I prefer Ticagrelor? Why Ticagrelor? 12 reasons, right? Now the reason 1, because I can safely give it to pre-hospital patients. What do I mean by that, pre-hospital patients? I mean, as you know, when I admit my patients, I have to admit them. This Ticagrelor can be, even this is a chewable tablet. You know, a tablet can be safely given to the pre-hospital patients, as you can give aspirin, you can give Ticagrelor also. So my patients, while they're coming to the hospital, they can safely take from the chemist, or of course they're in emergency, when they land in the hospital casualty, they will be immediately given by my nurse or a technician who is handling, my doctor who is handling the patient. So that's why Ticagrelor. Next slide, please. Now, pre-treatment with Ticagrelor in STEMI. Now this is a trial, Atlantic trial, 1,062 patients, STEMI patients, which are randomized to Ticagrelor pre-treatment with no pre-treatment. And you see, when we are giving the patient the Ticagrelor before the hospitalization and in the hospitalization, the ST segment resolution in comparison to no TIMI3 in the infarct-related artery. So 75% of the patient, more than 72% of the patient, there was no ST segment resolution. Okay. And in hospital, no TIMI3 flow in the infarct-related artery. Next slide, please. So if you look at the secondary endpoints, when you compare with definitive ST segment resolution, all right, in comparison to pre-hospital as well as in-hospital patients, the number of patients who had events. Now, when you give pre-hospital, you can see the numbers. The number of deaths are definitely low. The bleeding rates are almost equal, maybe slightly more, but the p-value is not significant. But as far as the definite ST segment resolution is concerned, when you are giving the pre-hospital Ticagrelor, your definite ST segment resolution is significantly less, and even 30-day definite ST segment resolution is significantly better. Next slide. Now, why Ticagrelor? Because I can safely switch from clopidogrel. So when a patient who is say, for example, on clopidogrel, and I want to give them Ticagrelor, particularly for my angioplasty patients, like if my patient is coming to me from a peripheral center, even if he is not an interventional cardiologist person who is referring the patient to me, he would be giving clopidogrel. Now I have to go angioplasty. So adding Ticagrelor to clopidogrel is definitely safe, and that's why Ticagrelor. Next slide. Now you look at this PLATO study design. The patients are either non-STEMI or STEMI patients. Okay, clopidogrel treated patients, randomized within 24 hours of the index event, 18,000 patients. Now, if you see the clopidogrel treated patient, if pre-treated, no additional loading dose, total 300 plus 300, if PCI was planned, 600 milligram was given. In comparison to that, Ticagrelor loading dose 180 followed by 90 BD maintenance dose, 6 to 12 month exposure. And what was seen was primary endpoint of CV death, MR, stroke, and primary safety endpoints of total medical bleeding was seen. Next slide. And that's why Ticagrelor, because there is a mortality benefit here. Look at the next slide. So if you look at in this PLATO trial, it is the first and the only antiplatelet to demonstrate superior reduction in the CV death in comparison to clopidogrel. That's why Ticagrelor. That is what is about PLATO trial. All right, and the days after randomization, it is not only immediately, but after also later, you can see that there is definitely reduction in the death rate. Next slide. Now, why Ticagrelor again is because of its unique pharmacology. Now, what is that unique pharmacology all about? Next slide. Now, you know, there is something called as reversible binding. Say, for example, even if the early CABG is needed, the binding of Ticagrelor it definitely got a reversible effect. The quick reversal of the effect is there with Ticagrelor. That's why Ticagrelor. Next slide. Because its benefits are seen across the ACS spectrum, irrespective of the management whether you are invasive or non-invasive, that's why Ticagrelor. So it is not only in the PCI group of patient, like the patient who, like say for example, I put them on medical line of treatment and unstable angina or acute coronary syndrome patient, I'm planning for, say for example, revascularization with PCI, and it turns out to be medical management patient. Still, when you give Ticagrelor in comparison to clopidogrel, there is definitely benefit. So whether you are invasive or non-invasive, the benefits are in both the spectrums of the ACS. That's why Ticagrelor. Next slide. The mortality reductions in invasive and non-invasive group seen. Now you can see in these slides, both the patients who are either invasive or non-invasive, the mortality reductions are seen. Now these are the reductions in the invasive group of patients. If you see, and in comparison to clopidogrel, there is definitely mortality reduction. Next slide. And even in the non-invasive group, there is definitely mortality reduction. That's why Ticagrelor. Now its benefit occurs over a period of time. Even after 12 months, the benefits are seen. That's why Ticagrelor. Next slide. Next slide. So if you see the patients, long-term secondary prevention. So in comparison to 90 milligram, when you are giving a 90 milligram BD dose and later on when you are choosing to give 60 milligram BD dose, the benefits in comparison to placebo, they are definitely seen better in the Pegasus trial, the 21,000 patients with prior MI randomized to Ticagrelor 90 BD to 60 BD or placebo, the benefits are definitely better even after the long-term group of patients. Now this is at the 3 years. Next slide. Because I can crush the tablets without loss of platelet inhibition or even better platelet inhibition. So I can crush the tablet. Like as I told you in the beginning itself, like a Disprin tablet, this Ticagrelor can also be crushed and can given. That's why Ticagrelor. And even better platelet inhibition is there when I crush my tablet. Next slide. Now, these are the patients who are randomized to crushed or integral Ticagrelor. The benefits of the crushed tablets are in fact better in comparison to the crushed tablets. So PT reactivity units, if you see, there is definitely benefit of the crushed tablet in comparison to the integral tablets of the Ticagrelor. Next slide. Because there is no unpredictability of clopidogrel, as you know, there is a clopidogrel resistance. There is no such thing called as Ticagrelor resistance. So, in comparison to clopidogrel, like which has got a resistance of around 5 to 40% even, So Ticagrelor has got no such thing. That's why there is no unpredictability of the clopidogrel phase. So Ticagrelor has definitely predictable benefits. Next slide. So there's no resistance. There's no hyporesponse. There's no resistance like clopidogrel. That's why Ticagrelor. Next slide. Because I can treat a wide range of patients with less concerns of contraindications or warning, like next slide. Like say for example, when I have to choose a better potent, potent drug than the clopidogrel, see patient has got say recent stroke or TIA, age more than 75, less than 60 weight, Prasugrel has got certain contraindications. So in that view, there is no such concern of Prasugrel, so that's why Ticagrelor. Next slide. So if you see the net clinical benefit in the bleeding subgroup of patients, so overall if you see the benefits, Prasugrel is overall better as compared to clopidogrel. Next slide, please. The Ticagrelor benefits are consistent across all subgroup, no subgroup after altered in relation to bleeding complications. So that's why Ticagrelor, like with the weight is less than 60, with the patient more than 75, whether there is recent stroke or TI. So bleeding risk is definitely more in the Prasugrel as compared to clopidogrel. So we are choosing Ticagrelor in comparison to Prasugrel to say so. Next slide. Because it is being studied across a wide range of patients with atherosclerosis, that's why Ticagrelor. Next slide. Like say for example, patient populations of the TRITON where ACS patients undergoing PCI, PLATO full spectrum of ACS, and there was pre-treatment available in the PLATO. There was no such thing with the TRITON, and even the clopidogrel loading was there up to 600 milligram. So in TRITON only 300 milligram. So there is a wide spectrum proof of concept. So that's why I take it. All right. Next slide. Ticagrelor because the superior platelet inhibition as compared to clopidogrel. So there is definitely a better platelet inhibition as compared to clopidogrel. That's why Ticagrelor. Next slide. So if you see the time course, the Ticagrelor has got a definitely better, platelet inhibition in comparison to clopidogrel. That's why Ticagrelor. Next slide. Why Ticagrelor? Because can use as a single antiplatelet agent even in the high-risk patients. That's what Ticagrelor. That's the last. Next slide. So in this Twilight Trial, bleeding benefits more MR stroke, no significant. So if you see in this Twilight Trial, next slide, very big maze were achieved even with Ticagrelor immunotherapy. Okay, so the bleeding risk was in fact higher with the dual antiplatelet compared with monotherapy. So the benefits of the Ticagrelor are definitely isolated. Ticagrelor use is also significantly beneficial. That's why Ticagrelor. That is the last and the most important useful benefit of the Ticagrelor. Next slide. So overall, if you see composite all-cause death mortality was definitely same. So that's why Ticagrelor. Next slide. So primary as well as secondary benefits were achieved in both the patients, both group of the patients. Next slide. If you look at, we can give the pre-hospital setting, monthly benefits can be given on the top of clopidogrel, no precautions like Prasugrel, can be choose all kinds of, so all these benefits if you look at particular patient, whether you use invasive, non-invasive, beyond 12 months, single, everywhere, all these benefits are seen. So that's why I love Ticagrelor. And it's a really beautiful drug, relieve a lot of stress, particularly interventional cardiologists, also non-invasive cardiologists. They will be definitely benefited. And you can definitely take it from me. The Ticagrelor is going to stay. I don't think there is any better thing that can come beyond Ticagrelor. Thank you so much. If you have any questions, please ask.
So, sir, there are some questions in chat box.
Hello.
Yes, sir, some
So
questions in
these are the
chat box.
questions, right? Yeah. So Dr. Varun Chavan has asked a question. Evidence suggests that ticagrelor to be superior to clopidogrel for at least 12 months following ACS. On your clinical practice, what is your opinion on this? Yes, of course. I believe that definitely completely agree with you, Dr. Varun, that ticagrelor is definitely superior to clopidogrel for at least 12 months following ACS. In patients with non-valvular AF plus stroke, can be used triple drug along with ticagrelor? No, of course not. We will not use and aspirin along with dabigatran. When you are a patient of the non-valvular AF plus stroke, where you want to use triple drug, I will not use ticagrelor or prasugrel. It is contraindicated. We can use only ecosprin, clopidogrel, and then this NOACs. Okay. Stroke in ACS patient where there is a less bleeding chance, but not compared to clopidogrel. So, in these patients, when you are using ticagrelor, okay, a patient who has got stroke plus ACS, okay, so if there is stroke plus ACS, I would still prefer clopidogrel only as an antiplatelet agent in comparison to ticagrelor. Okay, in this ACS patient, if I have to use this patient in stroke with ACS, if my patient goes for angioplasty, if he requires angioplasty, sort of hemodynamically unstable patient, of course, I would consider using ticagrelor, but still on the safer side, I would go requesting clopidogrel and maybe if required, uh, NOAC like agent, that kind of dual pathway inhibition having, not dual pathway, like this kind of triple therapy I may choose in comparison to the I would try to play safe. I will use, ecosprin clopidogrel and maybe warfarin along with a small dose of NOAC in these group of patients. Any other questions, please?
Hello, sir. So there are no questions in chat box. So can we wait for a couple of minutes?
Oh, yes, why not?
So, sir, there are no more questions. So, with your permission, shall we conclude the session? Okay, sir. So on behalf of organizer, I would like to thank you for your insightful and educative talk. Thank you, sir. So I'm ending the meeting now.